Hi, I'm George Triadafopoulos. I'm a clinical professor of medicine at Stanford. And as part of a symposium on sleep, food, immunology, and well-being, I'm going to cover a very important and very common topic, which is how to maximize lifestyle modifications in gastroesophageal reflux disease, or GERD. But first, let's start by covering the issue of how common reflux symptoms, such as typically heartburn and acid regurgitation, are at the population level. Many people these days go to the pharmacy and they use over-the-counter antacids, proton pump inhibitors, H2 receptor antagonists that are all available over the counter to treat their symptoms. However, many times that control is inadequate, or the symptoms become more frequent and more severe. At that point, they enter into the sphere of the primary care physician, who then either enhances or alters the treatment that they had been receiving on the over-the-counter basis. And then sometimes, depending again on the magnitude and severity of the symptoms, they are referred to gastroenterologists or other specialists such as ear, nose, and throat physicians, or allergists, or pulmonologists, and they're evaluated typically by gastroenterologists or even sometimes surgeons, who very rarely end up deciding about the performance of an operation for the reflux control. There's also a variety of endoscopic therapies that are available today that are typically performed by either gastroenterologists or surgeons, all of that aimed at controlling refractory symptoms of reflux. What is important to recognize is that there are several elements in gastroesophageal reflux disease and symptom induction. Not only you have the so-called aggressive factors such as bile and acid or a combination, but also you have defensive factors such as mucosal resistance and regenerative activity of the mucosal surface of the esophagus. All of these are aimed at protecting the person from having damage of the esophagus as well as symptoms. But all of that is then communicating to the brain through special receptors, and the perception of symptoms takes place, and that actually is the most significant element in gastroesophageal reflux because it impairs the person's quality of life. And it does that both in the awake state as well as a state of sleep or positioning of the body. So ultimately, it is a balance or counterbalance of all these factors that we need to consider as we manage these patients. As you can see in this slide that appears to be rather complex, we have elements at the level of the lumen, such as the epithelial cell renewal, the irritability of the luminal contents such as acid or bile, the function of the tight junctions in between the cells of the surface of the mucosa, the nerve endings at the surface of the mucosa, as well as acid-sensitive ion channels. All of these are playing a significant role in the induction of symptoms and injury at the superficial level. And then as you go down to the mucosal level, you have the participation of inflammatory cells, as well as a variety of activity that happens at the level of the basal layer of the esophagus that tends to hyperproliferate to protect the submucosal from any injury. At the level of the submucosa, you have a variety of inflammatory receptors, the effect of pro-inflammatory cytokines, and you have also nerve endings that are much stronger and take the signals of their irritation to the brain, causing symptom induction. So all of these components can be manipulated therapeutically depending on the circumstances. So it's important as you manage a patient with reflux, with whatever modality you're going to use, to keep those components in mind. In terms of the pathophysiology of gastroesophageal reflux, there are many factors, both offensive as well as defensive, The most critical one, of course, being acid reflux. But we also have in certain individuals the possibility of reduced salivary secretions, such as patients with Sjogren's disease or even elderly individuals or patients with psychotropics, people who have diminished peristalsis, something that's called ineffective esophageal motility. There are individuals who have weakening of the lower esophageal sphincter pressure, such as LESP, so-called. We have other individuals who suffer from delayed gastric emptying that allows or facilitates the retrograde movement of gastric contents into the esophagus, particularly under the circumstances of increased abdominal pressure. There is a possibility of diminished mucus secretion, again, in the context of anticholinergic use. You have people with structural abnormalities such as the loss of the angle of His or the formation of hiatal hernia, and obviously acid and bile reflux that are the most important and clinically and pharmacologically manipulated elements or offensive components to the reflux induction. As we're going to get into the understanding of the relationship between reflux and symptom induction, particularly in the context of positioning and sleep, it's important to refresh our memories about what's happening at the level of the gastroesophageal junction. There is the so-called thoraco-abdominal gradient at the lower esophageal sphincter level, shown here. What you have obviously shown here is the abdomen, the lower esophageal sphincter, and the thorax with the respective pressures at baseline. So as you can appreciate here, the thorax, because of its inspiratory-expiratory movement, creates a negative pressure, thereby facilitating influx of contents from the abdomen, which typically carries a positive pressure through a potentially either permanently or temporarily minimally resistant lower esophageal sphincter at the so-called respiratory inversion point, or RIP, allowing influx of gastric contents into the esophagus. So these pressure relations are altered in the context of positioning, sleep, food intake, etc. So all of that can be explored and manipulated therapeutically, again, to improve the patient's symptom control. Another important issue to recognize here is that not all gastroesophageal reflux disease is the same. The most common phenotype, if you will, is so-called non-erosive reflux disease, or NERD, followed by erosive esophagitis, which means that the tissue of the distal esophagus is damaged, and that is classified as Los Angeles classification B, C, and D, with higher grade being the D, which usually translates to a peptic stricture. There is a possibility of having associated hiatal hernia. There are patients who have refractory reflux disease even without injury. And we also face many times patients with the consequences of repair of ongoing damage to the esophagus by acid or bile, such as those with peptic strictures or Barrett's metaplasia, which is obviously a precancerous condition. And then we have another large number of individual patients with reflux who suffer from extraesophageal manifestations such as asthma, laryngitis, chronic cough, or sleep disorders. Another important point that I would like to emphasize here is that control of symptoms of reflux by usually a pharmacologic manipulation is not equivalent to control of the intraesophageal pH. In this particular study that we did some time ago, we found that if we were to take patients with reflux symptoms on proton pump inhibition therapy, after optimization of that proton pump inhibition therapy to either once daily or twice daily, depending on how controlled these people would become, we found out that a significant proportion of people on PPI that was controlling their symptoms still had ongoing abnormality, quantitatively speaking, of the pH in the distal esophagus. Again, to make the point that there is no direct correlation between symptom induction and pH control. So that's important to recognize, and that can happen more likely in patients with Barrett's metaplasia. Thereby, patients think that they are controlling their acid reflux because they have no symptoms, and yet there is ongoing subliminal damage to the esophageal mucosal integrity, leading to Barrett's esophagus, and then sometimes, unfortunately, leading into the development of esophageal cancer, which is detected relatively late in the process, carrying poor prognosis. So now I'm going to take you through the remaining of the talk, which is about lifestyle and modifications of lifestyle, and I will cover the issue of diet, the intake of meals late during the day just before going to sleep, the role of exercise, the role of body position during sleep, the role of obesity, as well as smoking. And let's start with the diet. As you can see on this slide, you have a very healthy diet, which is not the typical American diet, particularly in certain areas and certain cultures around the world. It is important here to recognize that we don't know really enough about what is the perfect diet. There are some preliminary studies that we and others have done to identify particular elements in the diet that can be manipulated, and I will try to give you a little bit of an overview of this in the next several slides. But first, let me show you a typical pH monitoring study. What you see on the y-axis is the pH from 0 to 9. On the x-axis, you see time, which in this particular case extends to 96 hours. If you allow the particular individual patient to undergo a study for a 4-day period, the first 2-day period you allow them to eat the regular diet that they eat normally, and then you measure the pH at the same time, and then at day 3 and 4 you give them a special restrictive diet, a so-called anti-GERD diet. You can see here that the acidity profile during the first 2 days is much more significant than it is during the latter 2 days of the study. So we have the ability to measure the pH, and again I want to emphasize here that symptoms and pH are not necessarily going together, but nevertheless you can actually assess patients for pH control as well as symptom control using this particular tool of so-called 96-hour ambulatory Bravo pH monitoring study. And that kind of technology allows you to then study the dietary components in the diet, the amount, the quantity, the consistency of the diet, and all kinds of other parameters, as well as it allows you to quantify symptoms over the course of the 4-day period. The pH probe that you place endoscopically then passes spontaneously in the stool. We don't retrieve it. The patient returns a little recorder that allows us to quantify the magnitude of esophageal acid exposure. We can then quantify the magnitude of esophageal acid exposure, and you can see here when the patients, this particular study is with all comers, are on a liberal diet, you can appreciate that the magnitude of acid exposure is quite significant. Anything above 6 is abnormal. This is 10.5. And then on restrictive diet, the majority of the people, typically about 50% overall, normalize that acid exposure time. And this is just with a dietary modification from the liberal to the restrictive diet, not with pharmacologic control, although you can accomplish similar results with pharmacology as well. This study shows the percent acid exposure time in various groups Here you have the erosive esophagitis group, or EE, that has obviously significant acid exposure under normal dietary treatment, and that reduces itself significantly, but not always normalizing it on the restrictive diet. And then you have another group of people with non-erosive reflux disease that typically have less acid exposure, which again can actually be reduced by acid controlling diet to either normal or minimally abnormal levels. And then control of that is the so-called functional heartburn group of patients who have heartburn and acid regurgitation, but they do not have acid reflux, again emphasizing the dissociation between acid exposure and pH changes in the distal esophagus. In that group of people with functional heartburn, we do not really see any significant difference in the reduction of the pH because they don't have really significant pH abnormalities to begin with. More importantly, as it pertains to sleep, I would like to show you this slide that shows the supine percent acid exposure, which is reduced with an anti-reflux diet, their so-called restrictive diet. And as you can see here, compared to the liberal diet, you have a significant reduction in the magnitude of esophageal acid exposure during the supine position. So diet and sleep are linked, and you can actually protect the patient by minimizing their diet to certain constituents as well as quantity to minimize any kind of abnormalities that occur during sleep. How about exercise? This is actually quite a significant issue for many patients with reflux. Even people who are not suffering from significant acid reflux, they may develop intermittent reflux symptoms during exercise. And I would like to spend a few minutes covering this particular topic, which again is very significant for many. This slide actually highlights the role of exercise, the type of exercise on the induction of reflux symptoms. You have a control situation of no exercise, then you have a healthy person who runs in a fasting state, and you can see here the percent of acid exposure if that person starts from normal to fasting running as well as fed running. And you can appreciate here that if you run after you have eaten, your likelihood of having temporary acid reflux during exercise is increased. So again, it's not a good idea to eat and then exercise. If you have a patient who exhibits symptoms during running, despite the fact that they're otherwise healthy, if they are comparing the fasting running state to the placebo running state to running after they have taken an H2 antagonist, you can see here the difference that you can make. So this particular slide emphasizes the potential of using H2 antagonists before the particular individual goes for a run, which has a high probability to develop reflux symptoms even in the fasting state as well as the fed state. Now let's talk about sleep and reflux symptoms. There is a very interesting relationship between sleep and reflux symptoms that we'll elaborate in the next several slides. Not only sleep may precipitate symptoms, but also reflux symptoms occurring during sleep may actually compromise the quality of sleep. But before we go there, I would like to make sure that I highlight the fact that abnormalities during sleep, to the degree that they are related to underlying esophageal issues, can be related to acid reflux, the classic GERD that we've been talking about, but also there can be associated with non-GERD conditions, such as conditions of esophageal dysfunction, specifically achalasia, esophageal gastric junction outflow obstruction, ineffective esophageal motility, or even gastroparesis, which allows and facilitates any kind of reflux, acidic or not, to come up in the esophagus. Some instances, for example, in the cases of achalasia, we may have intraesophageal reflux that is not acidic necessarily, but that is a reflection of stagnation of esophageal contents such as secretion, saliva, or even food in the esophagus, which, depending on the position of the individual patient, may cause abnormalities in sleep, as well as other abnormalities such as abnormalities in the lung function, coughing, or even reflux laryngitis that is not necessarily acidic. This is a very important slide that summarizes the reflux patterns and functions during awake as well as asleep periods. So the first thing to note here is that the pattern of reflux is different in terms of the position. When the person is awake, reflux happens typically in the upright position, sitting or walking, while during sleep, of course, happens during the supine position. The timing of the reflux in the awake period is typically postprandial, usually about an hour after a meal, not very quickly after a meal, just about an hour or two. During sleep, it is most common in stage 2 of NREM sleep. In terms of the frequency, during the awake period, the frequency of reflux typically is frequent, although during sleep it's not as frequent, but it may last longer. So the timing can be shorter during the awake period and much longer during the sleeping period. And that's a reflection, of course, of the clearance of esophageal contents, which is typically rapid while the patient is awake and more prolonged while the patient is in the supine position. In terms of other functions that are reflective or relating to reflux, the gastric acid secretion is typically high in the late evening as well as the middle of the night. The gastric emptying is typically delayed during the night. The frequency of the so-called transient lower esophageal sphincter relaxations, or TLESRs, is decreased in frequency during the night, but it is actually more common during the day. The upper esophageal sphincter pressure is decreased during sleep, compromising again the larynx or the lungs. The esophageal primary and secondary peristalsis, although it can be normal during the awake period, it can be reduced in the sleep period. The swallowing is reduced during sleep, and it only happens during brief arousals. Saliva secretion is typically reduced during sleep, and also the esophageal perception, as we talked about earlier, is decreased during sleep. All of these elements are interrelated, and they need to be carefully considered and thought out and managed appropriately depending on the circumstances. I wanted to make a few points about the so-called non-GERD conditions that can contribute to poor quality sleep and the relationship between sleep position and manifestations of reflux, be it at the level of the hypopharynx and larynx as well as the lungs. As we mentioned earlier, there is the achalasia and dysmotility, which is a situation that can be assessed more formally by the performance of an esophageal manometry. There is also another issue that we have not touched upon, the issue of the increasingly common eosinophilic esophagitis, which behaves very similarly and clinically very similar to acid reflux, but it is not necessarily acid related, but it's more of an allergy of the esophagus. You have the concept of functional heartburn or reflux-like dyspepsia, where you have symptoms of reflux, but you do not have acid reflux by pH criteria. and you have normal endoscopy, normal biopsies, normal pH monitoring, and you have also the condition of gastroparesis, which has an overlapping element of reflux symptoms as well as nausea, vomiting, abdominal bloating, and early satiety. All of these components need to be investigated formally by pertinent and relevant testing so one can make a better therapeutic decision making. This slide highlights the issue of early versus late meals and clearly shows that there is more likelihood for supine pathologic acid reflux if one consumes a meal late before they go to sleep at night, minimizing the interval between the completion of the meal and the positioning in bed. So it is very important, especially if you're planning to control symptoms that are nocturnal in nature and compromising sleep, to basically allow significant amount of time interval to elapse between the completion of the meal and the assumption of the supine position. This slide shows you that using this device called MedCline, which is basically a sleep positioning device, you can actually reduce the nocturnal acid reflux and esophageal acid exposure. So this allows the patient to have the head elevated while maintaining a recumbent left side down position, and that has been shown to be beneficial in many patients with nocturnal reflux and sleep abnormalities. You can see here that if you compare the supine or flat position to a wedge that is applied to keep the patient's head elevated versus blocks under the bed, you can still appreciate here a reduction of the esophageal acid exposure. This is the old classical method, very inexpensive and practical, but sometimes inconvenient for many individual patients. And obviously, as you can imagine, this is a reflection of improved clearance when the person is using a wedge or blocks to elevate the head of the bed, particularly having the left side down position compared to the standard supine position. This is a summary of a recent study that was published from the Netherlands that looks at an interesting device that actually tells the patient if they're in the proper position during sleep. So this involved almost 60 patients with reflux in a prospective study that used 24-hour pH monitoring and allowed to explore the effect of spontaneous sleep positions and the occurrence of nocturnal gastroesophageal reflux. And you can see here that when the person, as they turn, is notified by this device that they carry while they're sleeping, they can actually reduce significantly the esophageal acid exposure and acid clearance time by changing the position to the left side while they're asleep. In terms of the therapeutic strategies for reflux associated with sleep, we don't have too many great choices here. We obviously have patients who have reflux with sleep difficulties. Obviously, we talked about using medications before dinner, medications twice a day, sometimes using H2 receptor antagonists, using the head of the bed elevation, allowing a longer dinner to bedtime interval. But we have no real clear-cut data on the role of anti-reflux surgery, although many patients will tell us that it helps. Certainly, hypnotics, benzodiazepines, GABA-A agonists are not necessarily effective. So these are all approaches that one may need to consider when they're faced with patients with reflux with sleep disturbances as compared to patients who do not have sleep disturbances. Again, all that is driven mostly by demonstrating nocturnal acid reflux using pH monitoring. I would like now to cover the topic of obesity, which is a very significant issue in the reflux population. This is a slide that depicts the results of a monumental study done in the Framingham group that relates the BMI to gastroesophageal reflux symptoms in people who are of normal weight as well as overweight. This is the Framingham study that involves nurses, women nurses who participate in this study. And what you can see clearly here is that as the BMI goes up, the odds ratio for symptom induction of reflux is higher, and as the BMI is normalized or actually less than normal, the symptoms are much less likely to occur. This slide shows clearly that obesity increases the transient lower esophageal sphincter relaxation in healthy subjects. So as you go up in terms of the BMI, the likelihood of transient lower esophageal sphincter relaxations, even in healthy subjects, goes up, with obviously increase of the probability of pathologic acid exposure. Another way of looking at this is linking the BMI to the integrity or laxity, if you will, of the esophagogastric junction and the formation of hiatal hernia. And as you can appreciate here, as BMI goes up, the likelihood of a compromised esophagogastric junction, an increase in the diameter of the angle of His, as well as the formation of even transient intermittent small sliding hiatal hernia is increased. Finally, a few words about smoking, which is not a good thing for many other reasons, including reflux and sleep abnormalities. I'm only going to show you one slide that clearly shows that smoking decreases the lower esophageal sphincter pressure from normal levels to abnormal levels. Thereby, every time that one smokes, the transient lower esophageal sphincter pressure goes down transiently for the duration of the smoking as well as afterwards. And you can appreciate here that if one smokes, the sphincter pressures are reduced, thereby facilitating acid reflux and damage in the esophagus. And that is why we have a link between reflux esophagitis, Barrett's esophagus, and cancer in smokers. Finally, I would like to point out an important issue, which is the size of the meals. The fasting gastric volume as well as the rate of gastric emptying are altered in response to the meal size, and that actually plays a role in the improvement of the pH parameters and acid exposure time when a person follows a small volume, fat-free or less fat diet, because that does not allow a significant increase in the gastric volume as well as gastric emptying alterations. So the more the distension of the stomach and the less the clearance from the stomach, the gastric emptying, the more the likelihood of reflux. So small meals frequently as opposed to bigger meals, particularly very, very rich fatty meals, all of these are elements that contribute to reflux, also reflux in the supine position. And this is a slide that shows that decreased meal size and post-meal symptoms are associated with low fasting gastric volume as well as faster gastric emptying rates. Ultimately, from the therapeutic perspective, one should consider all options individually after careful study, depending on the results of these studies, that is the endoscopy, the assessment for hernia, the assessment for esophagogastric junction integrity, the evaluation by manometry to rule out other conditions affecting the muscle of the esophagus and the sphincter, as well as the pH measurements that we talked about already. All of these elements in the assessment process and the evaluation process will allow us to decide about either endoscopic therapy, surgery, or other novel therapies that are applicable today. In terms of endoscopic therapies, we have radiofrequency treatment of the gastroesophageal junction, so-called strata procedure. We also have transoral fundoplication, which is done endoscopically. In terms of surgery, we have the classic or modified fundoplication, and we also have gastric bypass, particularly individuals who have a high BMI. And we have also novel therapies that are increasingly utilized that have a more favorable, safer safety and tolerability profile. All of these decisions are to be made after a careful assessment of the particular patient. So in conclusion, many lifestyle factors affect gastroesophageal reflux in health and disease, and modification of these factors may reduce esophageal acid exposure and benefit symptoms. Refractory reflux symptoms may or may not reflect reflux disease, and other considerations need to be entertained here. Structural as well as functional evaluation of the esophagus are essential, but the impact and the comparative effectiveness of other factors to proton pump inhibition therapy or anti-reflux surgery remain unknown and will require further study. Thank you very much for your attention.